So it gives me great pleasure to introduce Dr. Liana Rood. She's a great friend of mine. We've known each other for 15 years now. We work together at Groote Schuur. She's been a pioneer of breast surgery and helping our government patients getting access to treatment. She runs an NGO called Project Flamingo. Without, our waiting times at Groote Schuur would probably be about 2 years to get surgery. She does lists at multiple hospitals now across South Africa where the NGO pays nursing staff and hospitals so that we can get patients done. We thank you, Liana, and we're looking forward to listening to your talk. I'm sure it's going to be great.
Thank you so much, Francois. Thank you for the organizing committee for having me. It's such a pleasure speaking to all of you. When Sarah called me and invited me to speak and I looked at the topic, it may be confessional, maybe a little bit of projection, but my first thought was, is surgery maybe experiencing like a teeny tiny midlife crisis? Wondering where is our role going to be in a few years as part of the management of breast cancer. So much has changed, and if you look at the history, it's actually quite phenomenal. So this talk is, like any therapist will tell you, if you're struggling with an identity crisis, it's a good idea to go back to the past to see where you've come from and how far you've come, where you're at, in order to decide where you are going. So this talk is a little bit of history, it's a little bit of philosophy, it's a little bit of personal opinion with some science scattered in there. So see it as a little bit of mid-morning pre-lunch entertainment, and hopefully we can have some conversation afterwards. I think I may leave you with more questions than answers, but let's see where this goes. Oh, I should probably change the slide. Okay, so literally this is going down the rabbit hole. And for me, what prompted the identity crisis, during my training, what was asked of me was very much, and I totally bought into it, this warrior, hero, surgeon energy. Like, you come in with your knife, you save the day. In breast cancer, we operate, we fix most of the problem. We all know that really is so far from the truth where we sit today. And how I feel today is that what is asked of me is some weird combination of shamanic divination and Jedi futuristic thinking, holding together a million threads, being part of a big team, and quietly wondering how long I will still be needed in that team. So really what I did is go back to the history, and I must say breast cancer surgery, even though it's sometimes looked down upon from other surgical disciplines, I mean, it's just a big lump we're operating on, has actually been quite instrumental in the development of surgery and how surgery has grown as a discipline. And it's such a beautiful example, the papers that I read, where we really went from mutilation to beautiful medicine. The question now is, of course, are we going from radical to perhaps even redundant? So, I mean, breast cancer surgery and tumors of the breast were first described almost 3,000 years ago already. It has quite an illustrious history. And, we find reference in it from the Egyptian papyrus to the Hippocratic theories, Garland's dissections, to where we are at today. And really, it really illustrates this close relationship between surgery and medical modalities and how we must maintain this relationship. So for 2 millennia, I think surgery, well, maybe we only thought so, but we thought we ruled the roost in terms of the treatment of breast cancer, of breast cancer, and that certainly isn't the truth anymore. And if I had to distill of the 10 or 20 history papers that I read, the 3 big lessons was actually to delve into the history is to rediscover buried insights. It was very interesting for me to read Galen's perceptions 200 years after deity. where he already figured out or described breast cancer as actually a systemic disease. Well, he called it black bile, so okay, not quite what it was, but that was later echoed in Bernard Fisher observations in the 20th century and he, a surgeon, really was the guy that called for that signaled the clarion call to reorientate breast cancer treatment to less radical surgery and towards other modalities. The evolution of therapeutic weaponry raises the fortunes of medical disciplines, like antisepsis and anesthesia is done for us as surgeons. And then again, it also minimizes the supremacy as a standalone choice for cure, like chemotherapy and radiation is done for surgery. So there's this constant balance and play between disciplines. And really what we need to learn is that stooping to conquer is the mark of survival in contemporary medical practice. And I think surgery has done this, and I think should continue to do it to actually stay part of this team. So I should make a t-shirt for myself, pivot or perish. I think that's where we're at as general surgeons or breast surgeons. And for me, if I had to distill down the points of evolution and change where we are being challenged and we're being tucked a little bit, is really where we fit in the coordination of the patient journey, where we fit in the diagnostics, how our surgical approaches to the breast have changed, to the axilla has changed, and then that we really have to face the dawn of artificial intelligence as a very real surgical partner. So in terms of the coordination of the patient journey, for me it is that warrior energy, that gladiator, that really does not work anymore with our patients. So maybe there's just something in the water, in the Helderberg, in the winelands, or it's the wine, I don't know, but my patients are asking a lot of me to have the patience and to develop the language, to really be able to connect with them, because you often still are the first point of call, and you really have to have a deep understanding of the pathobiological basis of breast cancer and be able to translate that to the patient so that they can understand their treatment options and understand why you advise what you're advising in terms of the treatment journey. It must be patient-centered, team-aligned. You're often counselor, you're often mediator, because there's a tug of war, what should happen, and you have to advocate for the patient's best care, because patients have very clear ideas of what they're willing to do and what they were not willing to do. And certainly in my practice, not only, and there's lots of evidence, a rise in patients opting for rather alternative than allopathic treatment modalities. Certainly there's evidence that up to 73% of breast cancer patients will use alternative therapies with their cancer treatment. I still think it may be, and then there is definite increasing numbers in patients refusing our allopathic treatment altogether. So that really has changed, the shaman, Then the next one is diagnostics. So surgery and surgeons have always been critical in the diagnosis of breast cancer. Are we in danger of becoming completely redundant in the diagnostic process? Perhaps. I think image-guided techniques is no longer negotiable. So much safer, so much accurate. And the question that we now need to ask ourselves as surgeons, if we want to remain part of this process, is it safe in a surgeon's hands? And is this something that we really should start pursuing and actively teaching and educating on? And then, does surgical excision have any place with the availability of VAP and vacuum-assisted excisions? So I think there is evidence, and now we're not talking diagnostics. We are talking, we're actually talking biopsies. Ultrasound-guided biopsies of non-palpable breast masses by surgeons, I think there's really good evidence emerging that it is safe. ultrasound is being used as like a stethoscope in clinical practice now. So, and it just makes sense that it evolves as an aid in doing biopsies. But I think what's really important in our setting is that if we look what's happening elsewhere in the world, it is accredited and it is trained and it is evaluated. And if we want to be part of it, then as surgeons, we really need to embrace it and make sure that we get ourselves certified appropriately in South Africa as well. And then, of course, I'm just going to skip over this in the sake of time, but we have to also be aware that while we're still debating whether we should get involved with image-guided biopsies, there's already a next frontier, which is the use of artificial intelligence in biopsies, and we should stay abreast of this and be part of it, and have dynamic discussions with our radiologist partners of where we fit into this. So for me, the considerations really is to be very cautious with diagnostics. I think we should stay out of it. All of it must be confirmed with formal imaging and radiology review and biopsy, at least for now. We must standardize and certify competency in the use of radiology outside of radiological practices. But we also have to realize that especially in South Africa, where we are so resource constrained, it may offer a very elegant and feasible solution to streamline patients. And it is a real opportunity for us for skill set enhancement and to remain relevant. Diagnostic surgical excision, I think I'm going to talk very quickly about it because it was discussed right before the break. The B3 lesions was what I was really going to focus on. But for me, I guess my general rule is don't operate until you know what you're operating on. Unfortunately, I don't know if I'm the only one struggling with this. I find myself once a week during my day case list standing there looking at a wire that's being placed, trying to get a diagnosis on a patient. That is often medical aid driven, that refuses to pay for vacuum-assisted biopsies, often patient driven, that refuses to go for biopsies under local anesthetic, and that is often resource driven. So wire placement, again, actually out. There's so many better techniques, yet again, often find myself with a wire placed because medical aid won't pay, and all of those other things. So, and then of course the aim of vacuum excision really is to replace the surgical biopsy. What are we going to do with that? We know the guidelines now. We certainly are trying to follow it. The question is, are we going to try and upskill ourselves as surgeons to do these procedures, or are we going to hand it over and leave it to our radiologists? So next is the surgical approaches to the breast. So I couldn't help myself, I just had to include these pictures of these fabulous tools that was used for breast surgery. It's not that long ago, that's the scary part. Holstead's mastectomy, radical, mutilating, now doing these beautiful incisions, getting stunning results with oncoplastic mastectomies, with safe preservation of the nipple areolar complex. I think I'm not going to go into, there's so much that shifted in breast surgery. I think for me, a great advancement was the safe preservation of the nipple areolar complex, as it adds so much cosmetically to the patient. And we've got really good evidence now that it can be oncologically safe. There was also concern about tumor distance from the nipple areolar complex, and more evidence is emerging that it's no longer an absolute contraindication. However, we should still do our intraoperative shavings. And something that I found very helpful now is the use of surgical delay techniques in order to improve the blood supply to the nipple. So basically doing a nipple incision with a nipple shave, closing, leaving the patient alone for a week, and then go back. And we've got a much higher, and there seems to be a much higher nipple survival rate. So those are great things, making the surgery so much more elegant and beautiful for both the surgeon and the patient, of course. Then, I'm not going to talk, you all know all these trials we all know breast conserving surgery, that is what you need to advocate for. There's only minor shifts that's happened for breast conserving surgery. The only real remaining contraindications for, is even with multicentric disease, you can now offer it to patients. If the lesions are close enough together and you've got good enough evidence that there isn't disease in the rest of the breast. So really the only patients that you're not going to discuss this with is the presence of diffuse malignant appearing calcifications or disease, previous any contraindications to radiotherapy, pregnancy, again, even just depending on the trimester and how far the radiotherapy window is, and then persistently positive margins. However, the big thing with breast conserving surgery is the increasing and preferential use of oncoplastic procedures. So no longer just, go take out the lump, actually do it beautifully. And offering patients concurrent reductions, using reduction patterns to actually do the surgery, making the radiation afterwards much easier, giving the patient a much better outcome. And actually there's good evidence that there's higher levels of satisfaction, lower complication rate, can you believe it? And it may actually be better than your standard breast conserving surgery. Right, so then the question, the elephant in the room, is the scalpel becoming obsolete in certain circumstances? So for the sake of time, I'm not going to go through everything, but I think cryoablation for certain tumors is the one thing that is being discussed. There's trials to keep your eyes on. For the moment, I think the only patients that, we want to offer it on is those that has significant contraindications to surgeries and that has low-grade tumors. That's hormone sensitive. But definitely something to keep an eye on. Okay, and I think cryoablation is not going to be the only method that is going to be explored in the future. And then, of course, the other area where the scalpel, or where a lot of work is being done, looking at whether the scalpel is going to become obsolete, is the complete de-escalation of surgery among patients with HER2-positive and triple-negative breast cancer that receive neoadjuvant chemotherapy with a complete pathological response. So, basically in the setting, patients with triple-negative disease with an excellent response to neoadjuvant chemotherapy would be the ideal candidates for surgical de-escalation. So if we can develop post-neoadjuvant chemotherapy image-guided biopsies, potentially combined with machine learning algorithms, we may be accurately able to identify patients achieving a complete response that would be eligible for complete omission of surgery. We're not there yet, but there's a lot happening in this arena, and this doesn't answer the question of what to do about the axilla. So I'll make all of this available if you feel like reading on your flight back. I'm not going to, talk through everything with you. But basically, we want to be able to, the challenge at the moment is identifying the patient that really had a complete pathological response. What is the best way to do it? Image-guided with adequate tissue sampling, and then strict follow-up. And there's quite a few trials ongoing, Responder, Nostra, and then that there's also trials that's sort of a bit cautious about it, that you can definitely go and look at, the MICRA trial, where the criteria is currently being developed at MD Anderson, Memorial Sloan Kettering. Where it is leaning towards is the use of MRI and stereotactic biopsy rather than ultrasound-guided, definitely vacuum-assisted biopsy, and then the residual imaging abnormality must be less than 2 centimeters. And it must, of course, be adequately sampled and adequately followed up. Lots of ongoing trials that you can keep an eye on, but it would be interesting for us as surgeons to see where this goes and where it leaves us. So then, of course, the surgical approaches to the axilla. I think all of you are well aware that this is where, we have seen significant de-escalation in surgery, and for very, very good reason. Not going to go through all the trials, but we're not yet at a point where we can say we can safely omit operating on the axilla. Again, I think, I'm just going to skip through this for the sake of time. Trials for me that I'm watching is the sound trial, sentinel node versus observation after axillary ultrasound, to see where that is going. The NESIMA trial, both examining the role of preoperative axillary ultrasound versus a sentinel lymph node biopsy in a clinically node-negative patient. And then I think the other place where the axilla really has, prompted a lot of discussion is obviously the approach to the axilla in early triple-negative breast cancer. So I'm going to skip here a little bit. So post-neoadjuvant chemotherapy. So initially node negative, we do a sentinel node biopsy. Initially node positive with a poor response, we still do a clearance. And then there's this third group where a lot of discussion has happened. If the patient was initially node positive with a good response, can we now only do a sentinel node? Yes, with DEAL technique and removal of the initially biopsied and marked node. Okay, so methods of doing this: placing a clip preoperatively, MagSeed or a radial marker, tattooing, radioactive iodine. So my personal approach is a MagSeed or a radial marker with the use of radioactive iodine for the sentinel node, removal of the node, if not the marked node, as well as the marked node, plus 1 to 2 echelon nodes if they are present. Okay, then selective axillary dissection, all of that. Okay, I'm going to move along. Basically, so all of this, it's complex and it's dynamic and it's exciting, and it's so important that we continue doing this in a multidisciplinary team setting and work together to figure it out. So the dawn of AI as a surgical partner, I think I'm actually not going to talk too much about it because there's so many wonderful talks during this Congress that focuses on it. But a lot is happening, and it can be potentially a very, very powerful partner for us in surgery, particularly in the planning of our surgery. So with 3D digital breast cancer models with multimodal fusion algorithms that can guide us in our excision, and even more excitingly, we will actually have intelligent apparatus, intelligent scalpels, intelligent equipment in theatre that can distinguish between normal tissue and affected tissue that can guide better and more accurate excision of tumors. So these technologies are developing at warp speed. When and how we will have them available here where we practice, I don't know, but I'm certainly quite excited about it. So my final thoughts for now, I think knives are still in, not quite out yet. What is required more than ever for the breast surgeon is curiosity. We need to stay open. We need to continue to learn and broaden our skill set. Teamwork is going to be of the utmost importance. We need to be agile. We need to maintain and increase our technical competence, even in fields that was not traditionally our playground. And we really do need to deepen our understanding of the patient's psychology and needs, because they are ever asking more of us and constantly in a position where we're all very clear on what we know we should do and could do, and find ourselves in a situation where it's not being done. So thank you for taking the journey with me, and I look forward to questions or lunchtime discussions.
Thank you, Liana.